Good morning. Thank you all for joining us today for the 2022 Richard and Barbara Hansen Distinguished Lecture. I'm Edith Parker. I'm Dean of the College of Public Health, and I'm delighted to welcome you all here today. The Hansen Leadership Award is our college's highest honor. Through this award program, we have a unique opportunity to recognize a national leader who has made outstanding and sustained contributions to advance the field of public health. For more than 20 years, the Hansen Award has been bringing outstanding individuals in public health to our campus here to interact with our students, faculty, and the broader community. This year, on top of having the occasion to recognize and hear from a truly distinguished public health scholar, we're delighted to be able to host this special event in person for the first time since 2019. Yay! And also welcome those of you who are joining us virtually. Just to let you know, we're also recording today's lecture and we'll make that available through our website in the future. Before I introduce today's speaker, let me take a moment to recognize and thank the very generous couple who made this event possible, Richard and Barbara Hansen of Iowa City. With their gift to establish this award in 2001, Dick and Barb were among the earliest supporters of our College of Public Health, our very first founding partners. Their gift has really helped to shine a light on the critical role of public health in our society, the values and impact of our discipline, and the importance of strong visionary leadership in guiding the work in our field. We're deeply grateful to the Hansens for their tremendous friendship and support and regret that they cannot be with us today. As a group, recipients of the Hansen Leadership Award are among the foremost leaders, advocates, and agents for better health and a more equitable society. This year's award recipient certainly adds to the distinction of this prestigious group. Dr. David R. Williams, the Florence and Lauren Norman Professor of Public Health, Chair of the Department of Social and Behavioral Sciences at the T.H. Chan School of Public Health, the Harvard T.H. Chan School of Public Health, and also Professor of African and African American Studies and Sociology at Harvard, is our 2022 Hansen Award recipient. Previously, he served on the faculty of Yale University and the University of Michigan. He holds a Master of Public Health degree from Lebanon University and a PhD in Sociology from the University of Michigan. Dr. Williams is an internationally recognized authority on social influences of health. He's the author of more than 500 scientific papers, and his pioneering research has shaped our understanding of the ways that race, socioeconomic status, stress, racism, health behavior, and religious involvement can affect physical and mental health. The everyday discrimination scale that he developed is the most widely used measure of discrimination in health studies. Dr. Williams was elected to the National Academy of Medicine in 2001, the American Academy of Arts and Sciences 2007, the National Academy of Sciences in 2019, and he currently serves on the Board of Trustees of both the Robert Wood Johnson Foundation and the W.H. Kellogg Foundation Solidarity Council on Racial Equity. Throughout his distinguished career, he has played a leading and highly visible role raising awareness of the problem of health inequities and also, and most importantly, identifying interventions to address them. Many of you may be familiar with Dr. Williams from the PBS film series, Unnatural Causes, Is Inequity Making Us Sick?, for which he was a key scientific advisor. He was also part of the National Academy of Medicine committee that prepared the landmark Unequal Treatment Report, which explored how persons of color experience the healthcare environment and the disparities in treatment that arise in healthcare system. Following today's lecture, Dr. Williams will take a few questions from the audience, and for those who are attending in person, please write the questions on the note cards you received when you came into the auditorium, and we'll have people who collect the cards and pass them up during the Q&A session. And for those of you who are joining us via Zoom, please submit those questions through the Q&A feature on the webinar. Now, it's my great pleasure to welcome Dr. Williams. David, we very much look forward to your remarks entitled Understanding and Effectively Addressing Health Inequities in Health.
Thank you. Thank you very much, Dean Edith Parker. It's a privilege to be here. I said yes immediately when I saw her invitation. because we were great colleagues together at the University of Michigan. And so she's a dear friend and admired colleague. And it's really good to be here. I've driven through the state of Iowa many times, headed somewhere out west, but never really spent time on this campus. So it's really great to be here. I have a lot of territory to cover, so I'm going to just jump right into my talk about how do we understand and effectively address inequities in health. I want to begin by the fact that there are racial, ethnic inequities in health in the United States and around the world. In the interest of time today, I'll just talk about the United States. Here is data that illustrates them. Infant mortality, the chances of a baby dying before its first birthday. And you could see that African Americans, Native Hawaiians and other Pacific Islanders, Native Americans, all have markedly elevated rates of death. And COVID-19 has made racial health disparities much worse because of its disproportionate impact. Here is data on age-adjusted odds ratios of deaths through 2020-21. At that time, there were 520,000 deaths. There are now over 1 million deaths. We're comparing the death rate to that of whites, and you can see the indigenous and Native American population, Latino, Black, and Pacific Islander population all had rates of death from COVID-19 that were more than twice those of whites. And this impact of the disproportionate impact of COVID-19 has produced a large decline in life expectancy from 2019 to 2020, a decline that is larger than we have seen since 1944. And you could see the decline was largest among Hispanic and African American males, with a decline of over 3 years, over 2 years for Hispanic and African American females, and over 1 year for white males and females. And racial ethnic inequities are not a new problem. They have existed for a long time, and they are persistent over time. One example of this is life expectancy by race 1950 through 2020. And we have data only on blacks and whites that go back that far. And you could see there's good news and bad news in the data. The good news is life expectancy has increased over time from 1950 to 2010 for blacks and for whites. You can also see between 1950 and 2010 a narrowing of the black-white gap, an 8-year gap in 1950, a 4-year gap in 2010. At the same time, if you look at the life expectancy of whites at birth in 1950, 69.1 years, how long did it take for African Americans to equal the health that whites had in 1950? It was not until 1990, 40 years later, that blacks experienced the overall level of health that white had experienced. And you can see from 2010 to 2020, and it really reflects the impact of 2019, the impact of the pandemic. You could see a 4-year gap in life expectancy between blacks and whites in 2010, a 6-year gap in 2020, and you can see life expectancy overall in 2020 for both blacks and whites is lower than it was in 2010, the same point I made earlier about the impact of COVID. So what drives these large racial inequities in health? It was something I was interested in trying to understand as a doctoral student in sociology at University of Michigan. What are these drivers? And this work by Stanley Lieberson, a sociologist, was very important in terms of thinking of causality. He emphasized the importance of distinguishing basic or fundamental causes. Those are the drivers of an inequity, from surface or intermediate causes, are factors that are related, that predict it, but they're not the drivers of it. And using his work, my dissertation was on socioeconomic differences in health. And I wrote a paper arguing that socioeconomic status, measured by income, education, occupational status, was in fact a fundamental cause of inequities in health. And Bruce Link and Joe Phelan have elaborated on SES as a fundamental cause and documented this role in very powerful ways. And race ethnicity in the United States and elsewhere is strongly related to socioeconomic status. So it's a clue to the racial differences in health that we see. Here is national data for the United States, median household income by race in 2018. I am translating the data into a way you can't miss the point. I'm standardizing on the median household income of whites is $1. For every dollar of household income white households receive, Asian households receive $1.23. Asian households have markedly higher levels of education. It's also a heavily immigrant population, and they have more persons contributing to household income than any other group. So if I had had a per capita measure of income, whites would have the highest. But let's look at the historically disadvantaged populations. For every dollar of household income that white households receive in 2018, Latino households receive 73 cents, and African American and Native American households receive 59 cents. What is stunning about the 59 cents figure for blacks, that is identical to the black-white gap in income in 1978. You heard me correct, I did not misspeak. 1978 was the peak year of the narrowing of the black-white gap as a result of the anti-poverty policies and the civil rights policies of the 60s and 70s, and the gap was reduced to 59 cents. And in 2018, it is still 59 cents. Has it been stuck at 59 cents from 1978? No, it got worse throughout the decade of the 1980s, and it was not until the mid-1990s it got up to 59 cents, and it's a penny up and down since then. The point I am making, though, that's an important take-home point, is that the racial, ethnic inequities in socioeconomic status, as captured here by income, is much larger than most of my students think it is, and that most of Americans think it is, and we have made much less progress than most people think it is. I'm arguing that we've really been on a treadmill. And these large racial gaps in income markedly understate the racial gap in economic status. What do I mean by that? Well, income captures the flow of resources into the household, but it tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth that captures the savings, the investments, home equity, all the assets, economic assets that individuals have. And according to the Federal Reserve Board, for every dollar of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. And why that is so relevant is when a household is low in income and low in wealth, while we may all be in the same storm of the pandemic as we were in COVID-19, we're not in the same boats. And both in the households that are low in income and low in wealth can be one paycheck away from being homeless and then one paycheck away from being able to face their family. When my career started, most researchers thought that the racial ethnic gaps in health were simply a function of racial ethnic differences in income and education. And that if we looked at blacks and whites, for example, at the same levels of income and education, race would no longer matter. We now know that life is more complicated, as I and one of my students argued in a 1995 paper. Let me show you data. National data for the United States. Life expectancy at age 25. And it's going to illustrate the power of socioeconomic status and the power of race ethnicity. So at age 25, the average white person will live 5 years longer than the average African American. That's a 5-year gap. But if we look at socioeconomic status by income and education within each racial group, in the interest of time, I'll only show you the education data, but the pattern is similar for income data. There is a larger gap within whites by education than the racial gap. A 6.4-year gap between whites who have a college degree or more education and those who have not finished high school. And the same is true within African Americans, a 5.3-year gap, again, bigger than 5, between the highest education African Americans and the lowest education African Americans. At the same time, because some have argued based on this data, SES is a bigger predictor, we shouldn't bother with race. Why even bother with race? Well, race matters at every level of income and education. So white high school dropouts live 3.1 years longer than black high school dropouts. And as education and income increases, the gap widens. And here is a stunning statistic. Remember, this is national data for the United States. The best off African Americans, in terms of health, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who graduated from high school. So what do these data tell us? They tell us there's something about income and education that matters for your health regardless of your race. But there's something else about race that matters even after you've taken income and education into account. And back in 1997, I wrote a paper in which I argued that along with socioeconomic status, racism was also a fundamental cause of racial disparities in health and a driver of even the differences we see by race in socioeconomic status. So let me talk briefly about the house that racism built. When I use the term racism, I think not primarily of the beliefs and behavior of individuals, but an organized system, a system that categorizes and ranks populations, devalues and disempowers some, differentially allocates resources. Yes, it's premised on an ideology of inferiority that some population groups are better off than others, and it can lead to negative attitudes and beliefs, prejudice and stereotypes, and differential treatment, discrimination by both individuals and social institutions. But racism affects health in multiple ways. Back in 1996, I was able to persuade Richard Cooper, the editor of the journal Ethnicity and Disease, to allow me to be the guest editor for a special issue of the journal on the racism in health. It's the first special issue, to my knowledge, of a journal dedicated just to the topic of racism, and there were 14 papers published illustrating the multiple mechanisms by which racism operates to produce inequities in health. I want to talk about three major mechanisms today. The first, structural or institutional racism, and I will illustrate that with residential segregation, not as the only one, but a really powerful one. Wrote a paper arguing that racial residential segregation was a fundamental cause of racial disparities in health with Chiquita Collins. We were not unique or novel in making that case. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa got the ideas of apartheid from us. They looked across the Atlantic in the early 20th century, saw how well residential segregation was working in the United States, and they said, brilliant, we can implement that in our country. Importantly, Sell argues that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States. And you're saying, what does segregation have to do with health? Well, think of segregation as a burglar at midnight. When it slips into the community, valuables begin to disappear, like quality schools and safe playgrounds, and access to good jobs and a healthy environment, and access to safe housing and high-quality medical care and transportation. Research in the United States indicates all of these desirable resources vary by place, by neighborhood, by zip code, by where you live. How powerful is segregation? Two of my colleagues at Harvard, two sociologists, William Julius Wilson and Robert Sampson, studying the 171 largest cities in the United States, said there's not even one city where whites live under equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities, all produced by residential segregation. And if you're paying attention, that's a 1995 study. So have things gotten better over time? Let me draw on another colleague, Professor Dolores Acevedo Garcia. She's now at Brandeis University. She has created an amazing neighborhood opportunity index, ranking every county in the United States on 29 different indicators of access to opportunity for kids. On the 5 domains, but it's things like the quality of schools, the home ownership rate, the median household income, the environmental quality, resources for green health. And this is a 2020 Health Affairs paper, so this is up-to-date data. What she did, she analyzed all children in the United States in the 100 largest metropolitan areas. And she asked the question, which children live in very low and low opportunity neighborhoods? 2/3, 67% of all black kids, 58% of all Latino kids, 53% of all Native American kids live in very low or low opportunity neighborhoods, compared to about 1 in 5 white and Asian kids. On the other hand, who lives in high and very high opportunity neighborhoods? Almost 2/3 of all white kids and Asian kids, compared to 1 in 5 African American and Latino kids. And what research has told us very compellingly is that place and these opportunities at a neighborhood level are the drivers of the racial ethnic inequities in income and education that we see in the first place. Want evidence? I'll share with you the work of two Harvard economists. First, David Cutler. Using national data for the United States, fancy econometric models I cannot even fully describe, but he's able to show statistically, if you could eliminate residential segregation, you would completely erase nationally in the United States black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of these striking differences are linked to opportunity at the neighborhood level. And then another Harvard economist, Rash Chetty, he asked an intergenerational question, looking at census data over multiple decades. And he asked the question, let's look at black and white children who start out life in households with the same level of income. How are the black children doing in the next generation? And he finds that black boys have lower earnings than white boys in 99% of census tracts in America, controlling for household income. Why? Because they're lazy? No, they live in neighborhoods that differ in access to opportunity. Black boys do just as well as white boys if they live in neighborhoods in good resources, but that's true of only 1% of black boys in the United States. So what do these data tell us? They tell us that residential segregation, this upstream mechanism of racism, has produced racial inequities in health that do not reflect a broken system. Instead, they reflect a carefully crafted system functioning as planned, successfully implementing social policy, many of which are rooted in racism. The inequities we see are not accidents, are not acts of God. They illustrate the ways in which an upstream mechanism of racism has produced a truly rigged system in the United States. And a review paper we did looking at the impact on segregation, on access to care and the quality of care, that persons in segregated neighborhoods have lower levels of health insurance, have providers with a reduced ability to refer their patients to specialty care. There are fewer pharmacies in those neighborhoods, although the cost of pharmaceutical products are more expensive in those neighborhoods. Hospitals are more likely to close in those areas, resulting in delays in care and the receipt of suboptimal care. And my research and the research of others have shown that when you are low in economic status and you live in disadvantaged, segregated neighborhoods, you experience higher levels and greater clustering of economic stressors, of psychosocial stressors, of physical and chemical stressors. So a broad range of risk factors are linked to clustering in place. So we've talked about this upstream mechanism, segregation, and what it has produced. There's also discrimination at the individual level. Martin Luther King suggested that discrimination was a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. Now, Martin Luther King was not a scientist. This is a hypothesis, though, that could be tested. And I and others have developed measures of discrimination that we could assess. And this is the first paper published. We're reporting the findings of the everyday discrimination scale and documenting what's the impact of the subjective experience of discrimination as one type of stressful experience that had been neglected historically. What is striking about the everyday discrimination scale, it doesn't capture all aspects of discrimination. Actually, it's only one of 3 of the measures that I developed, but it's the one that has been the single most predictive. Just little indignities. Being treated with less courtesy and respect than others, receiving poorer service than others in restaurants or stores, people acting as if they think you are not smart or if they're afraid of you or they think you are dishonest. Just a bunch of little indignities. The findings for everyday discrimination are stunning. I am surprised by the strength of the findings. One of my doctoral students just did a meta-analysis. There are over 450 published peer-reviewed papers globally using the everyday discrimination scale. And the next slide is just going to summarize some of the aspects of health that it predicts. People who score high on everyday discrimination, studies show, adjusting for other confounders and other risk factors, more likely to develop metabolic syndrome and cardiovascular disease, an independent predictor of incident breast cancer and type 2 diabetes, engagement in risk behaviors that lead to poor health, multiple indicators of subclinical heart disease like heart rate variation, AFib, intima media thickness are all predictive. Higher levels of hypertension, poorer sleep quality and quantity, higher levels of inflammation and stress hormones like cortisol, shorter telomere length, higher levels of obesity, less engagement with the healthcare sector, and higher levels of mental disorders and psychological distress. Just some of the health outcomes that a high level of discrimination predicts. Today, we have studies from the United States, the United Kingdom, Australia, New Zealand, and South Africa that find statistically, when you look at racial differences in health and you adjust for income and education, there still is a residual effect of race. That effect is further reduced when you add a measure of discrimination to the model. So we now know empirically that discrimination, the subjective experience of discrimination, is a contributor to the racial disparities in health. And then we also know there are hidden ways in which stressors linked to race and racism adversely affect health that are not captured by the everyday discrimination scale. Here is a study that found that over 70% of Black women in America are concerned that their children might be harmed by the police. I have 3 daughters and a wife, and all of them are very concerned that something might happen to me one day because I'm a Black male in America. Here is a study published that these concerns are not without reason. A study published just last year of over 3,000 mothers in 20 cities in the United States, and 1/4 of urban youth are stopped by the police by the age of 15. And mothers of youth who were stopped by the police were more than twice as likely to report both depression and anxiety-related sleep difficulties. So there are costs for family members. Here is another study done by myself and along with one of my former students and other colleagues. What we did, we took a database of every police shooting in the United States accumulated over 3 years. And then we linked it to a database from the CDC of the mental health of the population in every state. And what we found was every police shooting of an unarmed Black person was linked to worse mental health, not just for the family and friends, but for the entire African American population in the state in which that shooting occurred, and the elevated levels of mental health symptoms existed for 3 months in relationship to every police shooting. Importantly, it wasn't every police shooting. It was only every police shooting of an unarmed Black person. If the African American person shot by the police was armed, there's no effect on mental health. It was a specific effect. And we think that what it captures, the fact that a person was unarmed, meant it could happen to you, number one. You don't have to be doing anything wrong, but it's this greater sense of vulnerability for you and for the entire community when that happened. And then there are what I call Amina storm clouds, all the stress of racism and the impact it's having on young Black children. And this study is one of the most disturbing studies for me that I have read in the last few years. It's a study that was looking at suicide in elementary school children in the United States from 1993 and 2012. And what the study found, among kids 5 to 11 in America, the suicide rate was stable overall. However, further analysis by race found that it was stable only for Hispanic and Asian children. It had markedly declined for white children and had doubled for Black children. A follow-up study found that this pattern of the doubling of higher rates of suicide for Black boys and girls compared to their white counterparts, where the rate is twice as high, is through 5 to 13 and was evident through 2015. And it raises the question for me, see, when I was in elementary school, I don't know that I knew what suicide was. And to think that elementary school children are committing suicide at this high rate was very alarming to me. And it raises the question, what does it feel like to be a Black child growing up in America today? And what are we going to do about it? Study published earlier this year tells me the exact reason for suicide. A study of kids, mean age 11 years old. Black youth reported higher suicidality than other youth. And what predicted it? Exposure to racial discrimination. In fact, when the researchers added racial discrimination to the model, the effect of race goes away. It's completely driven, the elevated suicidality, by exposure to racial discrimination. So we've talked about the ways in which racism operates. Structural, institutional racism, individual discrimination. There's also discrimination embedded in the culture that leads to stereotypes and implicit and explicit biases. Unequal treatment was mentioned in my introduction. I served on this Institute of Medicine, now National Academy of Medicine committee that documented across virtually every therapeutic intervention, from the most simple to the most complicated. That means a person in the emergency room with a TIA, a mild stroke. Black patients less likely to get aspirin. Or complicated medical procedures, blacks receive poorer quality care, less intensive care than whites. It's 20 years since the report. We're doing a special meeting in March of next year to commemorate, not celebrate, commemorate the 20th anniversary of the report. And there's evidence that the pattern persists. I just will show you one study that doesn't give us the reasons, but shows how disturbing the pattern is. This is a study published in 2020 of 1.8 million hospital births in Florida from 1992 to 2015. When cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. Disparity cut in half when black babies are cared for by a black doctor. This study by itself doesn't tell us what the causes are, but it shows a troubling, disturbing pattern. So I've talked about the problem. What can we do about it? First of all, we need to build more health into the delivery of medical care. And one step along that line is to ensure access to care for all. We have high quality evidence that this would make a difference. Wouldn't solve the problem completely, but it would make a difference. Second, building more health into the delivery of medical care, we need to diversify the workforce to meet the needs of all patients. I want to share with you a study done in Oakland, California, a randomized control trial. Took African American males on a Saturday morning, gave them a coupon to go to a nearby medical center, for a free screening. When they got to the center, they were randomized to see a black doctor or a doctor of another race. And what the study found, remember this is an RCT, so high quality scientific evidence, those black men who saw a black doctor were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get a flu vaccine, more likely to do the screening for cholesterol. So much more engagement with the healthcare system when there was racial concordance. We face a challenge. In 2014, there were 27 fewer African American males in the first year of medical school than there had been in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2019, 5% of physicians are black, 6% Latino, 0.3% Native American. So we have a long way to go. But I have good news. Another study from Northern California of racial differences in HIV/AIDS. And the study found there were disparities in the receipt of the appropriate treatment, in patients following through on what their provider told them to do, and in the treatment actually working to provide viral suppression. Then the researchers analyzed their data. They had administered a cultural competence scale. And what they found was that when cultural competence was high, regardless of the race of the provider, there were no racial disparities in health in this study. Now, it doesn't tell us how to get to high cultural competence, but I want to show you what high cultural competence looked like by sharing with you some items from the scale. Providers who were high on cultural competence were providers who said family and friends were as important to health as doctors, who said that social history contributed to how they care for their patients, who said they were familiar with the lay beliefs their patients had, who said they asked their patients about alternative therapies they use, who said they find out what their patients think is the cause of illness, who said they involved their patients in decisions about their health care. What emerges from these questions is the quality of a relationship, of listening to the patients, of respecting them, of learning from them, of asking questions. And when those conditions existed, regardless of race of provider, there were, in fact, no racial disparities in health. What else do we need to do? We need to provide care that addresses the social context. The World Health Organization asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? So how do we take a more comprehensive approach and address the challenges that individuals face? A recent report from the National Academy of Medicine on integrating social care into the delivery of medical care. Please go get the report. It's online. You can find it and read it from National Academy Press. It lists multiple examples of programs from medical legal partnership to the nurse family partnership program that are doing this and are making a difference in the delivery of care. So I've talked about interventions within the healthcare sector. What else can we do? We also need to identify and highlight the supportive, protective factors and resilience resources that protects populations from at least some of the negative effects of racism. And here is one example, a dramatic example of the power of social ties, of the quality of social relationships. A study done by Gene Brody and his colleagues. They were studying African-American teens in rural Georgia. They assessed among these teens discrimination that they had experienced at age 16, 17, and 18. And those teens who were consistently high on discrimination as a teen, by age 20, I didn't say age 40, I didn't say age 30, by age 20, biological dysregulation was evident among them. High levels of stress hormones, cortisol, epinephrine, norepinephrine, high levels of blood pressure, of inflammation, and of BMI at age 20 linked to being high on discrimination as a teen. However, among those teens who experienced high levels of discrimination, who were embedded in close, positive social relationships with their family, with their teachers, and with their peers, there was no relationship between being high on discrimination and biological dysregulation. So the quality of social ties buffered, protected them from the negative effects of their exposure. Similarly, national data for the United States finds that there's a relationship among African Americans between exposure to discrimination and worse mental health. However, they found three aspects of religious engagement: frequency of religious attendance, reporting that they received social support from members at their congregations or place of worship, and seeking religious guidance in their everyday life. Each of these reduced the negative effects of exposure to discrimination on mental health. So religious resources can play a role. And then a study from Canada. At the time of the study, First Nation adolescents in Canada had the highest rates of youth suicide in the world. Researchers went into those communities to study them and found that more than half of the 196 First Nation communities had no youth suicides at all in the last 5 years. So they began to wonder, what distinguishes? Here's a group that has high rates of suicide, and some, more than half, have no suicides at all. And they found 5 markers of challenging the government to titles to land, for the right of self-government, of control over their services, education, healthcare, fire, and having a place in the community where they taught the young people their culture and their history. And the researchers found that each indicator of advocacy, protest, empowerment, and cultural affirmation was associated with a lower risk of youth suicide. And they found a strong dose-response relationship. The more of these you had, and if you had all of them, there were no youth suicides at all. Talking about the role of getting young people engaged in protest, advocacy, empowerment is a powerful mental health strategy because it gives them a reason to live and gives them a way to fight for the future and to make a better world. But we need to move further upstream. We need to implement policies to reduce social inequities in health. And it's what I call, we need to develop communities of opportunity to minimize neutralize and dismantle the systems of racism that create inequities in health in the first place. That means, if I've talked about the centrality of segregation and the conditions it creates, we need to enrich the quality of neighborhood environments, increase economic development in poor areas, improve housing quality and the safety of neighborhood environments, and build more access to opportunities in those communities so you can see those impacts. And so I have a paper with Lisa Cooper that lays out all the strategies that can be implemented, and I don't have time to discuss them in detail, but how we can reduce childhood poverty and enhance income and employment opportunities for youth and young adults. In the interest of time, I'll talk briefly about the evidence for two of them. Invested in early childhood and improving neighborhood and housing conditions. The Abyssinian Project in Chapel Hill, North Carolina, is an example of, again, high-quality scientific evidence. A randomized controlled trial where poor children, 80% of them African American, at birth, were randomized to receive an enriched early childhood development program. Nurturing environment, good nutrition, good pediatric care, good intellectual stimulation. The intervention was birth through 5. After 5, nothing was done. By age 21, those who got the intervention compared to the control group, better mental health, lower levels of drug use, more active lifestyle, better academic performance, greater success in the job market. By the mid-30s, they have markedly lower levels of risk factors for cardiovascular disease and metabolic disease. Just one example, here's a systolic blood pressure in the control group, and the treatment group is a group with the intervention. Birth through 5, striking differences in obesity, in multiple indicators of metabolic syndrome in the mid-30s. And research of these interventions find they actually save society money. So why aren't we doing more of this? Beats me. Second, improve neighborhood and housing conditions. We have an example, the Move Into Opportunity program, that took residents of public housing, randomized some of them to move to less poor housing, no health intervention. 10 to 15 years later, those who had moved, better health, lower rates of obesity, lower rates of diabetes, just linked to changing the neighborhood environment. When I've talked to policymakers, some people think, but it's impossible. It's too hard. How can we do this on a larger scale? And I like to talk about the striking example of PurposeBuilt Communities. And the PurposeBuilt Communities is a program that began in Atlanta, East Lake Meadows, Atlanta, 1995. It was a housing project where rates of crime were very high. 90% of residents were victims of a felony each year. It was public housing, many units dilapidated, only 13% of adults gainfully employed. The nearby elementary school was one of the worst performing in the state of Georgia. The community leaders, some female community leaders in that community, came together with the Atlanta Public Housing Department and a wealthy philanthropist, and they tore down the public housing project and built the villages of East Lake. I was able to spend a day there with one of my colleagues, Jack Shankoff, 3 years ago, and it's just amazing to see the dramatic transformation. 73% reduction in crime, 90% reduction in violent crime, high quality, privately managed housing. Half of the residents qualified for public housing, half are at market rate. All adults are gainfully employed, and the school, although 60% of the elementary school students still qualify for reduced price lunches, so they come from poor households, 60%, the school is one of the best performing in the state of Georgia. And the PurposeBuilt model shows it can be done. It is possible to address all the challenges faced by poor communities simultaneously. It's possible to develop comprehensive integrated place-based solutions. It's possible to develop a high-quality cradle to college program for poor kids. It's possible to do all of this by offering wraparound services of social support, of employment, of workforce development, and so on. And Shirley Franklin, the former mayor of Atlanta, is the chair of the board of PurposeBuilt Communities, and PurposeBuilt Communities have made a commitment they will provide free technical assistance to any community in the United States who wants to implement their model. So far, more than 25 communities are implementing the Purpose-Built Communities model. So don't let anyone tell you it's too big, it's too complicated, we can't do it. It can be done. There are also examples of innovative initiatives from healthcare institutions. The one from Rush University in Chicago Academic Medical Center is a dramatic example where they have made a commitment. They will reduce the life expectancy gap from the poor areas of their service area to the wealthier areas of their service area by 50% in 10 years. And they have implemented an impact. In many communities, the healthcare system is the largest employer. It's the economic engine of the community, of the system. And they said we're going to leverage our economic impact to improve outcomes for the community with providing an employment preference initiative to persons who live in the community, using local capital for their capital projects, career development programs, having elementary and high school kids become involved with the healthcare system during the summers, developing apprenticeship programs for local residents, a local purchasing program. Whatever they can buy from a local provider, they will buy from a local provider from someone else. In other words, leveraging their economic resources to improve communities, and academic institutions need to do similar things. You leverage your economic muscle to strengthen the impact of the community. What is holding us back? What are the barriers we have to address? I would say there are three big ones. One is we need to raise awareness levels of the challenges, health and social, faced by disadvantaged racial ethnic populations. Research shows that most American adults are unaware of the disparities I have just described to you. Secondly, and it becomes more challenging, we need to build a science base that will guide us in developing the political will to address racial and other social inequities in health. And third, we need to build empathy. That is, identify how to tell the story of the challenges of the disadvantaged in ways that resonate with the public. This is not easy, but it can be done. We need to build the narratives that will help people feel the pain that others are feeling, so they say this is unacceptable in our country. And finally, since I'm being honored for my lifetime contribution, I want to reflect on what we need to do for the next generation. And academic research and practice institutions need to put the structures in place that identify, nurture, and mentor the next generation. I am not standing before you by chance. With all of my hard work, social support, divine blessings, would not have successfully launched my career without a minority fellowship from the University of Michigan. A minority fellowship that provided me financial support, without which I could not have gone to do my PhD, and also that I had 2 master's degrees when I applied, but my GRE scores were poor. I don't remember exactly what they were. I think I want to block it out of my mind. But my GRE scores were not great, although I had 2 master's degrees with good grades. So yes, I am affirmative action. As the Supreme Court considers affirmative action, remember, without affirmative action, I would not have been standing before you today. And at the University of Michigan, I was privileged to have a wonderful mentor, Professor James S. House, who was recently retired, who went out of his way to be a source of support to minorities and women. A mentor with a vision and a commitment, a mentor who really cared for his students. There's another colleague of mine, African-American female, who was also his mentor at the same time. And we had developed a nickname for him. We only told him so at his retirement celebration. And the nickname that these 2 black kids on campus had for him was Daddy. He was so caring and supportive. That was our nickname for him. And we need to put the structures in place now. And it wasn't only Professor Jim House. This was my dissertation committee. Ron Kessler, a great mental health researcher in the country, who worked with Jim House. I participated my 4 years in graduate school in the training program that he developed. So he's the second mentor, had a huge impact on my career. Dr. Walter Allen, also from the sociology department, now at UCLA. And then 2 faculty from the School of Public Health, Barbara Israel from Health Behavior and Health Education, and Victor Hawthorne, the chair of epidemiology at the time. So I had enormous support. And then I want to emphasize it takes a village. I got key advice from people at key moments of life that changed the trajectory of my career. Dr. Norman Miles, who had taught me and who advised me that I needed to go to the University of Michigan for graduate school. I was working in Battle Creek, Michigan. The closest school to me with a PhD program in sociology was Western Michigan University, 30 minutes away. University of Michigan was an hour and a half away, and I had thought, well, if I go to Western Michigan, wouldn't need to move. And he said, you need to go to the University of Michigan. And that made a difference for my career. Professor Alan Morris, they talk about what this stigma that individuals often have. I was on the job market applying for jobs. I saw the job posted at Yale. I did not apply. I said, Yale wouldn't be interested in me. And Professor Alan Morris met me in the hallway, walking my last year in graduate school, and he said, David, you're going to hear from Yale. I just talked to someone at Yale about you. I said, what am I going to hear from someone at Yale about? He says, well, they're looking for someone. They were asking who was good coming out of Michigan, and I mentioned your name. And I said to him, I'm not going to go to Yale. That's too much pressure. I just want a nice, small school. I can get my research done, do my work. And he said, David, let's go to lunch. And he took me to lunch a few days later and explained to me how academia worked and why where you go makes a difference. And yes, there may be more pressure, but there'll be more resources to deal with the pressure. And then finally, Professor James Jackson, a mentor par excellence, who mentored me as an associate professor and had a huge impact on my career. So let me conclude. The benefits of inclusive policies, creating these communities of opportunity to reverse racial injustice, will be beneficial to people of all races. Although the poverty rate is higher for African Americans and whites, if you look at the number of people who are poor, there are almost twice as many poor whites as poor African Americans. So when we develop these strategies that build community of all, we are helping everyone, and including many poor whites. I'll leave you with two quotations. Martin Luther King said, true compassion is more than flinging a coin to a beggar. It understands as an edifice which produces beggars, needs restructuring. I've talked about edifices that produces beggars that need restructuring. And finally, Robert Kennedy, speaking in South Africa in the 1960s, said each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that each one of us, in the hearing of my voice, will make a commitment to be a tiny ripple of hope. And together, we can sweep down mighty walls of oppression and resistance. Thank you very much.
Thank you so much, David. I'm just for a phenomenal lecture and just a phenomenal lifetime of contributions. That we're just so privileged to have you here today. So we can now have some time for questions. If you'll see that we have folks in the aisle, so you can pass a card forward, and we'll do that. Those of you who are online can use the question Q&A function on the Zoom, and maybe you can take a couple. Kind of hard to think when I have the presentation.
Questions or comments?
Thank you.
Thank you. Yes, I see a hand at the back.
Well, I was just curious to what extent you think the higher burden of exposures to environmental toxins contributes to the fact that zip code affects health so dramatically.
Absolutely. In my slide, when I talk about segregation, these are high levels of psychosocial economic and physical chemical stressors. So, for example, just to give you one example, there's studies of some of my colleagues at Harvard the Chan School showed that persons living in areas of high air pollution were more vulnerable to getting severe COVID and dying from COVID-19, for example. So yes, that is part of it. The environmental context is part of the negative impact of living in disadvantaged neighborhoods. And then there's also physical chemical exposures in employment areas, and then what jobs do people hold, and that's another area where there's higher levels of exposure as well. So great question. Thanks for helping me to emphasize that point. Yes.
And here's another one. Creating equal housing opportunity is one way to dismantle segregation, but how could this be supported in ways that diversify historically minority communities without creating fear among residents of gentrification?
It's a good question. I live in the Boston area. There is enormous gentrification taking place in the poor neighborhoods of Boston, where the poor residents have to move because they can't afford the dramatic increases in rental prices and have to move 20 miles further away from where they lived. And so gentrification is a huge problem. I mean, I think it can be solved in a sense within the PurposeBuilt model. They build this new area and they have 50% of the units reserved for persons who qualify for public housing, 50% at market rate. What happens in many housing development projects, they are set asides for low-income persons, but it's typically around the 5% level, and that's not at the level at which you are really impacting a large number of persons in the community. So the policy link, if someone wants to look into it, is an outfit in California. They have thought a lot about the questions of gentrification, and that would be one place to look to see some of the suggestions and so on. And there are multiple things that have been done in terms of minimizing the negative effects of gentrification, but it is a challenge.
Here's another one. So much of the evidence comes from cities and urban settings. How can we understand systemic racism in rural settings?
You were right. I think a lot of the research in general in public health has neglected the challenges in rural areas, and rural areas have challenges. I think one study I did cite, the Gene Brody study, was rural counties in Georgia. And that's an example of the problem of discrimination having really adverse impacts was evident among these black teens in rural counties in Georgia. So it is an issue, and the mechanisms may not always be identical, but although there are striking similarities across contexts of various structures and places that produce similar outcomes.
Got some more. The first part of this is, how were the housing projects in Georgia funded? Federal, state, other sources?
The model they use is they leverage. It was a partnership between the Atlanta Public Housing Department. They needed to get, this was a public housing owned land, so they needed that partnership. But one key to their model is to leverage the resources of private resources as well. And they have, like I said, 25 sites in the country that have replicated their model, getting wealthy private equity to come to the table in terms of providing some of the resources. It isn't only based on public funding, but it uses public funding as well as has a strategy, and I think that's the key. They have a strategy, they have a model that seems to be working in terms of attracting private equity as well to the table.
This is from one of our participants on Zoom. Are you seeing that medical students are increasingly taught about physiological effects of racial discrimination?
I don't work in a medical school. I write. There are papers I've written with Camilo Mateo, a physician, about what we need to do to transform medical education, and so on. I'm teaching a course. There are a number of MPH students in my class this semester who are, many of them, a few of them have taken a year out from the medical education. A few of them have their MD degree and are doing some of the program or residency or something else and are taking an MPH. And this issue was raised in class. And I'll tell you what two of the medical students said. They said they see a change in what they're being taught in medical school about understanding race and the limits of a biological view of race. They said they're getting that in their formal education in medical school. But they say when they go onto the units of the hospital and the supervisors that were trained in medical education decades ago, it's a different world. That they have no idea of where the science is now, and they are encountering in their clinical supervision the very deeply traditional views of race as fundamentally a biological construct. So there is work to be done in that space as well.
I think we're at time now, so join me in thanking Dr. Williams again.
Thank you.